Welcome to Unit 1, Hematology, Immunology, and Oncology. A CBC, or complete blood count, looks at the overall health of the blood. This test measures red blood cells, white blood cells, hemoglobin, hematocrit, and platelets. Each value gives us a clue about what's happening in the body, like infection, anemia, or a bleeding disorder. Platelets are especially important because they're the cells that help blood clot. A normal platelet count ranges from about 150,000 to 400,000 per microliter of blood. If that number drops below 100,000, the patient is at an increased risk of bleeding. If it drops below 20,000, that bleeding risk becomes severe and can be life-threatening. In critical care settings, there are many reasons why platelets may be low. Sepsis, heparin use, AIDS, and conditions like DIC or TTP can all play a role. Sometimes platelets don't work properly even when the count is normal, which can happen with like kidney failure, or maybe even after like heart or lung bypass surgery, or with certain medications like aspirin. From a nursing standpoint, safety education is really key here. We want to protect these patients from injuries that could cause bleeding. That means no razors with blades. We need to teach our patients to use electric shavers instead. Patients need to use a soft toothbrush and avoid activities that could cause trauma, like contact sports. Even simple fall prevention strategies become life-saving for patients with very low platelets. When we talk about coagulation, we're really describing the body's way of stopping bleeding when a blood vessel gets injured. So picture a cut on your skin. So the blood vessels constrict, platelets rush to that site, and then they stick together to form a plug. Then clotting factors, which are the proteins in the blood, those activate and form fibrin strands that act like glue to stabilize that plug. At the same time, the body has natural inhibitors that keep this process from going too far because we don't want clots forming everywhere. So anticoagulant medications are drugs that interfere with this process. They don't actually dissolve existing clots. Those are fibrinolytics, but they do prevent new ones from forming or current ones from getting bigger. So common examples are warfarin, heparin, enoxaparin, and the newer agents that we call the DAOCs, like Xarelto and things like that. So each of these works differently and requires careful lab monitoring to make sure the blood isn't too thin or too thick. From a nursing standpoint, we play a big role in safety. Again, always nurses play a huge role in safety. For patients on warfarin, we watch INR values to ensure that they're in the right range. INR, anything over the 2 to 3 when they're on warfarin, is a cause for alarm and it places the patient at increased bleeding risk. So with heparin, we check APTT. We also keep an eye on platelet counts because heparin can sometimes cause a dangerous reaction called HIT, or that heparin-induced thrombocytopenia, where platelets drop very, very low. So patient education is essential too, avoiding NSAIDs, which increases the bleeding risk, and maintaining a steady vitamin K intake if they're on warfarin. We don't want our patients eating too much foods that contain vitamin K, but we also don't want them eating too little. And that's because that can throw their clotting off balance here. So when caring for patients with an immunodeficiency, our biggest focus is protection from infection because their bodies can't mount a normal defense. So even something minor like the common cold, this can quickly become life-threatening. Strict infection control is the foundation. So hand washing with antiseptic soap really truly is the most effective way to reduce transmission. Protective isolation may be needed as well, and visitor restrictions are often put in place to lower exposure risks. We also think carefully about environmental precautions. Things like fresh flowers, raw fruits and vegetables, or contact with sick people can all carry microorganisms that a healthy immune system could normally fight off, but for these patients, they could cause a serious illness. A low microbial diet is often recommended here too. So monitoring for infection is critical. We can wait for a high fever to act, or we cannot wait for a high fever to act. So these patients may only show subtle signs. Even a low-grade fever, a new cough, a rash, or unexplained pain should raise concern and prompt immediate evaluation here. Anemia is essentially a problem of oxygen delivery. When the body doesn't have enough red cells, either hemoglobin or hematocrit, tissues don't get the oxygen they need. So this reduced carrying capacity is why patients with anemia often look pale, feel tired, and report being short of breath, even with small amounts of activity, because they don't have that oxygen carrying capacity. So clinically, we'll often see fatigue, weakness, pallor, tachycardia, dizziness, and sometimes even chest pain if that heart isn't getting enough oxygen as well. The severity of the symptoms depends on how quickly the anemia develops and how low the blood counts are. For example, someone with a slow chronic anemia may tolerate it better than someone with an acute bleed whose counts drop very, very quickly. Assessment really depends on both patient history and labs. Hemoglobin, hematocrit, and red blood cell count indices give us important diagnostic information. The type of anemia also determines the treatment. So iron deficiency anemia calls for iron replacement. Megaloblastic anemia, often from vitamin B12 or folic acid deficiency, requires those nutrients. So anemia from chronic disease may require transfusion or medications like erythropoietin to stimulate that red blood cell production. Aplastic anemia, which is much more serious, may need bone marrow transplant or immunosuppression. Iron deficiency anemia is one of the most common forms of anemia and often comes down to nutritional deficits or chronic blood loss. Since iron is needed to build hemoglobin, patients need both dietary and supplement support to restore these levels. When teaching patients about food choices, highlight iron-rich options like spinach, organ meats such as liver, fortified cereals, and dried fruits like raisins. These foods can help build up iron stores over time. Absorption is just as important as intake. Vitamin C helps the body absorb the iron, so taking supplements with a glass of orange juice is good practice. On the other hand, calcium and tannins found in tea and coffee interfere with absorption, so patients should avoid taking iron with those drinks. Supplements are often necessary, but adherence can be a challenge. Patients may notice dark stools or constipation, which are common side effects but not usually dangerous. Also, iron supplements can make people feel really nauseous as well, which they don't want to take it when they feel nauseous or feel gross afterwards. So educating them ahead of time really helps with compliance, and just letting people know, hey, you might feel really sick when you take this, or maybe take it with a little bit of food, which is going to help that absorption and really kind of settle your stomach ahead of time. So you can also suggest stool softeners or increasing fluid and fiber to manage that constipation as well. Pancytopenia means that all three major blood cell lines, so your red cells, your white cells, and your platelets, are reduced. This is usually the result of bone marrow suppression or just outright failure. When the bone marrow isn't producing enough cells, the body loses its ability to carry oxygen, fight infections, and prevent bleeding because all of your cell lines are affected. Aplastic anemia is a specific type of pancytopenia caused by bone marrow hypoplasia, meaning the marrow is underactive or empty. Patients often present with fatigue from anemia, recurrent infections due to low white cells, and bleeding or bruising because of those low platelets. For nursing care, we need to think about protecting these patients on multiple levels. Infection prevention here is key. So neutropenia makes even minor infections very, very life-threatening. Bleeding precautions are equally important. Patients may require transfusions and should avoid anything that increases that bleeding risk. And because their red blood cell count is so low, activity should be paced to prevent exertion-related shortness of breath and fatigue. The care we provide really helps reduce complications while they undergo treatments such as transfusions, immunosuppressive therapy, or even bone marrow transplant. When we talk about blood transfusions, it's not just about the numbers, it's about the whole clinical picture. Guidelines suggest that transfusion is usually indicated when hemoglobin drops below 7 grams per deciliter. In surgical or critically ill patients, that threshold may be slightly higher, usually around 8. But even if the values don't look severe, symptoms like chest pain, rapid heart rate, or shortness of breath should make us consider a transfusion. A key concept to remember is the expected response response. So 1 unit of packed red blood cells typically increases hemoglobin by about 1 gram per deciliter. That means we don't just give blood and move on. We need to reassess the labs and monitor how that patient is feeling. On the right side of the slide, you'll see the ABO compatibility chart. This is essential because giving the wrong blood type can trigger a life-threatening reaction. Type O negative is known as the universal donor, while type AB positive is the universal recipient. Always double check blood type, antibodies, and the match before hanging a unit. Blood transfusion safety is critical because even a small mistake can put a patient's life at risk. Before starting, 2 nurses must verify the order together. This includes checking the patient's name, blood product, blood type, and RH factor against the cross-match results. This double check process is in place to catch errors before the transfusion begins. Baseline vital signs should also be obtained. And then, of course, once the infusion starts, you need to stay with that patient for at least the first 15 minutes. That's when most transfusion reactions happen. We need to continue to monitor vital signs every 15 minutes during that first hour and reassess regularly throughout the transfusion. This is where you look at your hospital policies and procedures to know how often to do those vital signs and those checks. At our facility that I work at, we have to do them every 15 minutes for the first hour, and then after that it's every hour until the transfusion is done. So for administration, only normal saline is compatible with blood products. Lactated ringers and dextrose solutions are not safe because they can cause clotting or hemolysis of the blood product. So each unit must be infused within 4 hours, no longer, and new tubing should be used for every single unit of blood to reduce the infection risk. Another thing that we need to do is we need to wear gloves when we are handling the blood product. Your role as the nurse is to be alert, stay with the patient, and stop the infusion immediately if anything seems off, such as fever, chills, rash, or difficulty breathing. Patient safety depends on these steps being followed carefully every single time. When it comes to blood transfusions, our role isn't only about following protocols, it's also about respecting patient values and choices. Some patients may refuse the transfusion, either for religious or personal reasons, and that decision has to be honored. It's important to document their wishes clearly in the chart so the whole care team is aware. For patients who can't or won't accept blood, there are some alternatives. Medications like erythropoiesis stimulating agents can help the body make more red blood cells. Supplements such as iron, vitamin B12, and folic acid can support production as well. In some cases, patients may use autologous transfusions. This is where their own blood is collected ahead of time and given back to them later, such as during surgery. This avoids the issue of immune rejection as well. So we play a key role in communicating openly with our patients. So that means explaining risks and benefits in a way they can understand, answering questions honestly, and working closely with that healthcare team to provide safe and respectful care. Our goal is always to support both the medical needs and the personal beliefs of the patient. When we think about transfusions, it's not just about red blood cells. Platelets and plasma also play a very critical role in supporting patients with bleeding problems. Platelet transfusions are given when a patient has very low platelets, often from conditions like thrombocytopenia or when their platelets aren't functioning properly. Even 1 unit can bump the platelet count up by around 30,000, which can make a big difference in reducing bleeding risks. Fresh frozen plasma, or FFP, is different. It doesn't replace platelets, it replaces clotting factors. This is really important for patients with conditions like liver failure, DIC, or those on anticoagulants when bleeding becomes an issue. We can see it's working when lab values such as PT or INR start to improve. Our job is to carefully monitor after these transfusions. That means checking for less oozing at IV sites, improved clotting, and reduced signs of bleeding like gum bleeding or bruising. Watching these signs helps us know if the transfusion is effective and whether the patient is stabilizing. When giving blood products, one of the most important things we watch are transfusion reactions. Two of the most serious complications are hemolytic and anaphylactic reactions. An acute hemolytic reaction happens when the patient receives blood that is not compatible with their blood type, usually an ABO mismatch. The immune system immediately attacks the donor red blood cells, causing them to break apart. This can happen within the first 15 minutes of the transfusion. Symptoms include fever, chills, low back pain, tachycardia, shortness of breath, and blood in the urine. It can lead to kidney failure, disseminated intravascular coagulation, and even death if this is not recognized quickly. An anaphylactic reaction, on the other hand, looks very different. So it's not necessarily about mismatched red blood cells. It's the immune system reacting to the proteins on that donor blood. So this can happen suddenly with hives, itching, difficulty breathing, wheezing, low blood pressure, or cardiac arrest. So this looks exactly like you would imagine any other anaphylactic reaction to look like. Think of like a bee sting. That's what this looks like as well. Epinephrine needs to be ready at the bedside if this occurs. So this is a rapid response. We need to hit the button and we need to get our team in the room very, very quickly. And for both of these situations, your priority as the nurse is to stop that transfusion immediately. We need to keep the IV line open with normal saline and notify the provider and the blood bank right away. And then, of course, as always, hit that rapid response button. When caring for patients receiving blood transfusions, it's also important to distinguish between transfusion-associated circulatory overload, or TACO, and transfusion-related acute lung injury, or TRALI. Both can cause respiratory distress, but that underlying cause and treatments are very, very different. So TACO is fluid overload. The body is given more volume than it can handle, especially in patients with heart failure or kidney impairment. So that's where this presents. Symptoms include all of those fluid overload signs or signs of like increased heart failure. So that includes that shortness of breath, crackles, hypertension, distended neck veins, and of course tachycardia. Treatment involves slowing or stopping that transfusion and giving diuretics like furosemide to pull off the excess fluid and placing the patient upright to improve breathing. So oxygen is often needed as well here. Think of TACO as a fluid overload. Our patient, this is the one transfusion reaction where it's not really a reaction, it's more just they can't handle the volume of the blood. So we're gonna have to need to slow that transfusion down. We can continue to give the transfusion here because they're not necessarily having a reaction to the red blood cells or the blood product, they just don't need all that extra volume. So what I like to tell my students is, they need that oxygen carrying capacity. They just don't need all the extra stuff, right? So we're giving them the red blood cells, but then we're going to give them a diuretic like that Lasix or furosemide to pull the fluid off and get them to urinate that fluid out. So they get to keep the good stuff, the red cells, that oxygen carrying capacity, but we just need to get rid of the extra fluid. So TRALI, on the other hand, is an immune-mediated response. This is one where we need to stop that transfusion and all of the things just like we do in the anaphylactic and the hemolytic response, okay? So inflammatory mediators make the lung capillaries very, very leaky. So this leads to non-cardiogenic pulmonary edema. So these two are very confusing because they can look very, very similar. So patients present with sudden respiratory distress, hypoxemia, frothy sputum, fever, and hypotension. Which think about your TACO. TACO is hypertension and TRALI is hypotension with a fever. So if you have a question, how you discern between these two is, one, for TACO, are they hypertensive? Do they have an underlying kidney disease? Do they have underlying heart failure? Are they hypertensive? Do they have a fever? Because if they don't, it's probably just fluid volume overload. Whereas with TRALI, you still have all of those signs and symptoms of respiratory distress, but now they're hypotensive because this is an immune-mediated response. And they generally have a fever because, again, this is immune-mediated and it has to stop. So treatment focuses on immediate discontinuation of that transfusion and providing supportive care. Oxygen, possible intubation even, and mechanical ventilation, and hemodynamic support for the low blood pressure. So unlike TACO, diuretics are not going to help here since it's not caused by the fluid overload. So recognizing the difference is key. So taco is treated by removing the fluid, while trolley requires supportive care for that inflammation and the lung injury. And so knowing the difference between these two can make all of the difference. When we give massive transfusions, meaning large volumes of blood products over a very short time, we have to watch very closely for complications. One issue is electrolyte imbalances. Stored blood can release potassium as those red cells break down, which raises the risk of hyperkalemia. At the same time, the preservative in blood, citrate, binds to calcium, which can drop calcium levels and lead to muscle twitching, tingling, or even arrhythmias if untreated. So just know large amounts of blood product can cause hyperkalemia and hypocalcemia. Two big ones that you guys absolutely need to know this unit and throughout the rest of the term, because this is coming back. Another complication, again, is that fluid overload, which is the taco we just talked about, and can show up as the crackles in the lungs, swelling, or difficulty breathing. It happens because the cardiovascular system simply cannot keep up with the rapid volume being infused. We also worry about coagulopathies or problems with clotting. Large volumes of red cells can dilute platelets and clotting factors. So without enough of these, the patient can bleed even when we're giving blood. This may require adding platelets or plasma to restore that balance. So the key takeaway here is that massive transfusion isn't just about replacing blood loss. It does require that careful monitoring and balancing of electrolytes, volume status, and clotting factors to keep the patient stable. Sickle cell anemia is a genetic disorder that changes the structure of red blood cells. Normally, red blood cells are nice and round, which helps them flow easily through the blood vessels and carry oxygen. In sickle cell anemia, the hemoglobin is abnormal, and under stress, dehydration, or low oxygen, the cells take on a crescent or a sickle shape. These misshaped cells are fragile and break down faster than normal red blood cells, leading to anemia. They also don't carry oxygen as effectively, which means tissues, organs, these aren't getting the oxygen that they need. Another major problem is that those sickled cells get stuck in the small blood vessels. This causes blockages known as vaso-occlusion, which cut off blood flow and oxygen. When this happens, patients experience what's called a sickle cell crisis, which is intense pain caused by that ischemia or low blood oxygen to the tissues. Over time, repeated episodes of sickling and blockages can cause serious complications like organ damage, higher infection risk, and even strokes. So the disease isn't just about the anemia, it's about how these misshaped cells disrupt circulation and oxygen delivery across the entire body. When patients come in with sickle cell crisis, our top priority is to break that cycle of sickling and blocked blood flow. The cells are getting stuck, so blood is thick and sluggish, and oxygen isn't reaching the tissues. This is why patients are in so much pain. We start with hydration. IV fluids help thin the blood, reducing that viscosity, and keep those sickled cells moving through the vascular system. It's one of the first and most important steps in managing a crisis. Oxygen therapy is another key intervention. By giving supplemental oxygen, we're trying to reverse the hypoxia that triggers even more cells to sickle in the first place. The goal is to increase oxygen delivery and decrease further sickling. Pain management is absolutely essential here. These vaso-occlusive episodes can cause excruciating pain. Narcotics are often required, and as nurses, we have to stay on top of pain control while monitoring for side effects like respiratory depression. So when you think about crisis care, remember to hydrate to move the blood, oxygen to stop the sickling, and medicate to control pain and allow the patient to rest and heal. It's important to understand what triggers sickle cell crisis so we can help patients avoid these triggers. A crisis often happens when something stresses the body, like dehydration, infection, exposure to extreme heat or cold, high altitude, or even surgery. All of these situations lower oxygen levels or increase stress on the body, which makes the red blood cells more likely to sickle and block blood flow. That's why patient education is so important here. We encourage patients to stay well hydrated, keep up with the infection prevention, and avoid things like strenuous exercise or traveling to high altitude areas without medical guidance. Even something as simple as a bad cold can be enough to trigger a crisis, so teaching patients to seek care early is critical and to stay hydrated. For long-term management, medications like hydroxyurea can help by making red blood cells less likely to sickle. Vaccines or infection prophylaxis also protect patients from illness that could start a cascade of problems. So prevention is really a combination of lifestyle adjustments, patient teaching, and medical management. Complications of sickle cell disease extend far beyond an acute pain crisis. Painful vaso-occlusive episodes are the most common problem and happen when sickled cells clog small blood vessels, cutting off oxygen. These episodes can be extremely painful and often come with fever or a general feeling of being unwell. One of the most serious complications is acute chest syndrome. This is considered a medical emergency and happens when sickled blood cells block vessels in the lungs. The patient may present with chest pain, fever, shortness of breath, and low oxygen levels. It can mimic pneumonia, but the underlying cause is the blocked blood flow. Without rapid intervention, this can be life-threatening. Long-term sickle cell disease can cause neurologic and organ damage. Patients are at higher risk for strokes, kidney problems, and a splenic infarction, which weakens their immune system over time. This is why comprehensive care and preventative strategies are so important for improving outcomes in these patients. As we prepare a patient with sickle cell disease for discharge, education is key to keeping them safe and reducing hospital readmissions. One of the most important points is hydration. When the body is dehydrated, blood becomes thicker and makes it easier for red cells to sickle and clog those little small blood vessels. We need to encourage our patients to drink plenty of fluids every single day, especially during hot weather or when they're more active. Infection prevention is another major focus because sickle cell patients often have damaged spleen. They're more prone to infections. Vaccinations, good hand washing, and reporting fever early can be truly life-saving. A fever in these patients should never be ignored because it can escalate quickly into a severe infection. Lifestyle adjustments also play a role in prevention, so patients should avoid things that stress the body, like high altitudes, extreme temperatures, or strenuous exercise. It's important they understand when to seek urgent care, such as when they have severe pain, chest pain, or sudden shortness of breath. Teaching these strategies empowers patients to better manage their disease and prevent complications. Thrombocytopenia simply means a low platelet count, and platelets are essential for blood clotting. When the number drops too low, patients become much more vulnerable to bleeding. This can happen for three main reasons. So the bone marrow isn't making enough platelets, the spleen is trapping them, or the body is destroying them too quickly. Chemotherapy and then also infections like HIV or hepatitis, alcohol use, or autoimmune conditions like lupus can all play a really big role here. The biggest danger comes when the platelets fall below 20,000. At that level, patients can bleed spontaneously, even without any kind of injury. They could sneeze and it could cause a head bleed. That could mean nosebleeds, gum bleeds, or even internal bleeding as well. Our job as nurses is to focus on prevention and safety. We encourage patients to use an electric razor instead of a blade, a soft toothbrush to protect their gums, and to avoid invasive procedures unless absolutely necessary. Fall precautions are key because even a small bump could result in dangerous bleeding. HIT is one of those conditions that really catches people off guard because it seems backwards. Normally, when we hear low platelets, we think bleeding risk. But with HIT, the immune system reacts to heparin and forms antibodies. These antibodies actually activate platelets, which leads to widespread clotting instead of bleeding. So what we'll see clinically is patient whose platelet count drops by more than half within about 5 to 14 days after starting heparin. It doesn't always fall below 20,000 like classic thrombocytopenia, but the rapid drop is a huge red flag. And at the same time, the patient is developing new clots like DVTs, pulmonary emboli, or even ischemia of the fingers and toes like we see in this picture. For nurses, the most important action is to stop all heparin immediately. Even things like heparin flushes and even central lines that are heparin coated. We need to get rid of all heparin. These patients will often be switched to a non-heparin anticoagulant. DIC is one of the most serious clotting disorders we'll see, and it's sometimes called a consumptive coagulopathy. So what happens is the body's clotting system goes into overdrive, so very similar to HIT. So tiny clots form throughout the circulation, using up platelets and clotting factors. So platelets and clotting factors are not infinite. We only have a very limited amount. And so when we have these disease processes and we start activating our clotting cascade, we can use up all of our platelets and clotting factors, which causes this huge cascade of events. So at first, this widespread clotting can block blood flow and damage organs. So again, very similar to HIT. But because the body has burned through its supply of clotting materials, the patient also starts bleeding, sometimes from IV sites, gums, or under the skin, such as petechiae. In practice, you may notice prolonged bleeding times on labs like PT or APTT, as well as oozing at line sites or surgical incisions. Patients may also develop organ dysfunction if the microclots cut off blood supply. For nursing care, the priorities are supportive. That means monitoring labs closely, assessing for new or worsening bleeding, and making sure the underlying cause is being treated, like sepsis, trauma, or obstetric complications. Platelet or plasma transfusions may be needed to help replace what's been used up, but they will not stop DIC by themselves. We have to treat the underlying cause here. Von Willebrand disease is the most common inherited bleeding disorder, and it happens when the body doesn't have enough von Willebrand factor or when that protein doesn't work properly. Normally, von Willebrand factor acts like glue, so it helps platelets stick to the damaged blood vessels and form that clot. Without it, platelets can't hold on as well, so bleeding lasts a lot longer. Clinically, patients might show up with easy bruising, frequent nosebleeds, heavy menstrual bleeding, or prolonged bleeding after minor cut or dental work. So labs often show a prolonged APTT because von Willebrand factor also helps stabilize factor VIII. But the PT is usually normal since clotting cascade isn't completely broken. So only half of the clotting cascade is broken. So APTT is usually prolonged and the PT is usually normal. So for nursing care, education is important. We want patients to understand their bleeding problem. Their bleeding problem isn't because they don't have enough platelets, it's because the platelets can't stick together. So treatments may include desmopressin, which boosts von Willebrand factor, or factor concentrates if bleeding is severe. Safety teaching around obviously avoiding unnecessary trauma or high-risk activities is also key here. When we think about who qualifies for an organ transplant, it's not just about whether the organ is available. Patients must meet strict evaluation criteria. They need to be healthy enough to survive surgery, free from active infections, and able to stick to the lifelong medication regimen afterwards. Adherence is huge because skipping anti-rejection meds can cause organ failure again. So there are also barriers to consider. Some patients may be disqualified because of uncontrolled medical conditions, unstable living situations, or psychosocial issues like active substance use. Financial barriers also play a role since post-transplant medications and follow-up care can be extremely costly. As nurses, our role is to advocate for patients through this process. We provide education so they understand what's expected, assess psychosocial stability, and help them connect with resources. By supporting them early, we can improve their chances of being eligible and successful after the transplant. When a patient is preparing for an organ transplant, one of the key steps is HLA testing, which stands for human leukocyte antigen testing. Think of HLAs as the body's ID tags on the surface of the cells. The immune system uses these tags to decide what belongs and what doesn't. If the donor organ has tags that look too different from the recipient's, the immune system may attack it, and this leads to rejection. HLA testing is done through blood work to compare the donor and the recipient. The more similar the HLA markers, the lower the chance of rejection and the better the chances for long-term graft survival of the organ. So it's important to explain to patients that while good matching lowers the risk of rejection, it doesn't prevent all complications. Surgery itself carries risks, and of course the lifelong medications to suppress the immune system will still be required. Our role is to make sure patients understand this balance so they don't go into the transplant with unrealistic expectations. After a transplant, patients are placed on immunosuppressive therapy. These medications are absolutely essential to prevent the body from rejecting the new organ. The trade-off here is that the immune system is intentionally weakened, which makes patients much more vulnerable to infections. Some of the most common infections we see include viruses like cytomegalovirus, fungi like Candida, and respiratory infections such as adenovirus. These infections can become very serious very quickly because the body doesn't have its normal defenses because they're immune suppressed. This is where nursing care is critical. We teach strict hand hygiene. We also practice strict hand hygiene. We need to limit exposure to crowds or sick contacts and recognize early warning signs such as fever, cough, or unexplained fatigue. Reinforcing medication adherence is also a huge priority in these patients. Missing doses of immunosuppressants can trigger a rejection, while inconsistent use can increase infection risk as well. During transplant rejection, the immune system sees the new organ as foreign and may attack it. Acute rejection usually happens within the first few weeks to months, and catching it early can make all the difference. Transplant rejection will manifest with the signs and symptoms of the organ that is failing. For instance, liver rejection will present like a liver failure patient. They will have ascites and increased bilirubin and liver function test, or those LFTs. The key difference is fever. Almost all organ rejections include a fever as the patient's immune system is weakened due to that immunosuppression. Some key symptoms of kidney rejection include fever, tenderness over the graft site, decreased urine output if it's a kidney, obviously, and sometimes high blood pressure. These changes reflect the inflammation and reduced function of that transplanted organ, and many of these signs and symptoms are similar to just normal kidney failure anyway, right? So we need to keep a close eye on vitals. So urine output and lab values like creatinine or BUN if it's a kidney, because that can show stress on those kidneys before symptoms even developed. So patient education plays a huge role. We need to stress that taking immunosuppressive medications exactly as prescribed is non-negotiable in transplant patients. Missing doses, even for a short time, can trigger rejection. And patients also need to report any new symptoms immediately to their provider so we can intervene quickly here. Once a patient has received a transplant, the real work is in protecting that graft long term. So the number one priority, and I know you're going to get tired of me saying this, is strict adherence to immunosuppressive medications. These drugs keep that immune system from attacking the transplanted organ, and missing even that single dose can trigger rejection. So it's something we emphasize over and over, as obviously we've done in this PowerPoint up until now, with our patients as well. So daily adherence is absolutely, again, non-negotiable. Lifestyle choices also play a big part. So patients should avoid crowded places or contact with people who are sick because that immune system is intentionally weakened. Routine health checkups help us catch any early warning signs of infection or organ stress before things get serious. And as nurses, we have to be teaching and reinforcing that role. It means checking if the patients understand their medication plans, clearing up any misconceptions, and then of course really listening for these barriers like financial concerns, side effects, or forgetfulness. Hematopoietic stem cell transplant, or HSCT, is a treatment that replaces diseased or damaged bone marrow with healthy stem cells. These stem cells can develop into all the different types of blood cells, so red blood cells, white blood cells, and platelets. We often use HSCT for patients with blood cancers like leukemia, lymphoma, or multiple myeloma, and sometimes for conditions like severe aplastic anemia or immune deficiencies. There are different types of transplants. So autologous transplants use the patient's own stem cells, whereas allogenic transplants use donor cells, and syngeneic transplants come from an identical twin. So allogenic transplants tend to carry the highest risk, but are also the most effective for curing certain cancers. Before transplant, patients go through conditioning with chemotherapy or radiation to destroy their diseased marrow and suppress the immune system so the new cells can take hold. The process is complete once engraftment occurs. So this means that the new stem cells are producing enough white blood cells and platelets for the patient to function safely without constant transfusions. Engraftment is confirmed when the neutrophil count stays above 500 for several days and platelets are at least 20,000. After stem cell transplant, infection risk is one of the most critical concerns we manage. During the first 2 to 4 weeks, patients experience profound neutropenia, meaning their white blood cell count is extremely low. This neutropenic window is the highest risk period, even when minor exposures can result in life-threatening infections. This is usually called nadir. Opportunistic infections are common and dangerous. Patients are especially vulnerable to fungal infections like Candida and Aspergillus, as well as viral threats such as cytomegalovirus or that CMV and adenovirus. So without rapid recognition and treatment, these infections can quickly progress and even kill our patients. To lower risk, we focus on prevention, as always. So patients may receive prophylactic antibiotics or even antifungals. Usually these patients are placed in HEPA-filtered rooms and follow a neutropenic diet. They're also on reverse isolation. So strict hand hygiene for both staff and visitors is, again, non-negotiable, just like those immunosuppressive medications. We also take special precautions with our blood products if our patients are receiving transfusions. All transfusions have to be irradiated and leukoreduced to reduce the risk of graft versus host disease and to prevent transmission of viruses like CMV. Acute graft versus host disease, or AGVHD, is one of the most serious complications following an allogenic stem cell transplant. It occurs when donor T cells recognize the recipient's tissues as foreign and mount an immune attack. So this inflammatory response typically develops within the first 100 days after transplant. The main target organs are the skin, gastrointestinal tract, and liver because these organs are what are naturally exposed to the external environment. So patients may present with diffuse red maculopapular rash, profuse watery diarrhea, and jaundice due to the elevated bilirubin. These symptoms can progress quickly and must be recognized early. Risk factors include poor HLA matching between donor and recipient, older patient age, unrelated donors, and a history of infections prior to transplant. I will say when we talk about HLA matching, one of the best types, obviously not all of us have identical twins, I sure don't, but if you have a sibling of the same sex, those are usually your best donors as well, for the most part. Not always, but usually those produce the highest HLA matching, just for your guys' information there. So each of these factors increases the likelihood of the severity of the graft versus host. So diagnosis usually requires a tissue biopsy here, but nurses play a vital role in monitoring for early warning signs, such as changes in the skin, worsening GI symptoms, or rising liver enzymes. So just know if you get a question, especially after allogenic hematopoietic stem cell transplant, any like big skin rashes, and these patients can have severe skin changes, GI or liver, like the increased bilirubin. So know those three systems, if those are affected after transplant, with a fever and all of the other things, it's likely acute graft versus host. That is how you differentiate, okay? When caring for patients with immunodeficiency, our number one priority is preventing infection. Even a minor exposure can lead to life-threatening illness for these patients. So strict hand hygiene, consistent use of PPE, and maintaining aseptic technique are essential nursing practices. I hope you guys are getting a feel for this theme here. Protective isolation practices are often implemented, especially during periods of neutropenia. Again, this includes the HEPA-filtered rooms, avoiding fresh flowers or plants, and restricting visitors to minimize microbial exposure. Equally important is patient and family education. Families need to understand the importance of avoiding crowded areas, practicing safe food handling, and reporting fevers or symptoms immediately. Early recognition and reporting can be life-saving, as always. So finally, frequent monitoring and early detection are critical. So nurses must assess vital signs often. We need to be looking at those CBCs with the differentials. And of course, we always need to remain vigilant, even the subtle signs of infection, which we're going to talk about SIRS criteria here in just a little bit. So SIRS, or systemic inflammatory response syndrome, is the body's generalized inflammatory response to infection, trauma, or other insults. It's diagnosed when 2 or more criteria are present, which is it can be a temperature greater than 38 degrees Celsius or less than 36, heart rate over 90, respiratory rate over 20, or a white blood cell count above 12 or below 4. So looking at this, you don't need a lot in order to have systemic inflammatory response. What really confuses students, I feel like, is temperature, because a lot of our temperatures are measured in Celsius. So how I explain this to students is, think of 37 degrees Celsius is normal body temperature. That is your 98.6. A degree above or a degree below that is going to be SIRS criteria. Something is wrong. Our patients are either mounting some sort of immune response. I will say cold shock is worse than warm shock. So if you think about a 37 degrees Celsius body temperature being 98.6, 38 degrees is 100.4, which is constituting a fever. So if 37 is 98.6, 38 is 100.4. So a degree above, that's considered a fever. That we need to treat that. Even if our patient's starting to elevate, we need to be looking at that, because now we're talking about increased metabolic demand. 36 degrees is like 96.8. So if our patients are below 96.8, that is a big red flag as well, because a low body temperature means that they maybe were just done mounting a response here, okay? Also, heart rate over 90, not 100. I do want to point this out. Normal heart rate is between 60 and 100. However, when we're talking about SIRS criteria or systemic inflammatory response, anything over 90 is considered high, okay? So that is going to flag as a SIRS criteria. Respiratory rate over 20, that is our physiological norm, right? 12 to 20. So anything over 20, that's the one that kind of makes sense. And then of course our white blood cell count. And remember, again, I feel like students always get this one a little confused too, because they always want to think it's going to be a high white count, but just like temperature, it can also be low, meaning that if they have a low white count, maybe they have some sort of pancytopenia or neutropenia, where they can't mount that defense, which also places them at risk, right? So if it's a high count above 12 or a low count below 4, that is always also going to trigger. You only need 2 of these. You don't have to have all 4. You only need 2 in order for your patient to determine whether or not they're mounting a response. And then, of course, the key here is that sepsis occurs when SIRS is triggered by that confirmed or suspected infection. You don't even have to have a known source of infection. All you have to do is suspect that the patient has an infection somewhere, and that is sepsis, okay? So I want to point out that 2 of these SIRS criteria, which isn't a lot, you could just have a temperature and a heart rate of 94, and you don't even have to have a known suspected infection. All you have to do is suspect an infection, and that patient has sepsis. It does not take much for our patients to be considered septic, okay, or linked to sepsis. So this is where we shift from a systemic inflammatory response, and now it's a life-threatening medical emergency, okay? We need to report sepsis criteria very, very quickly. And we need to be catching these early warning signs. We do not need to wait for a patient to be hypotensive or have increased lactic acid, which we're going to talk more about that in Unit 6 when we talk about sepsis and shock. We need to be catching this in this very beginning early continuum. If we are not catching this in the early continuum phases, then we have missed the ball and we are doing a great disservice to our patients. This is what separates a great nurse from a mediocre one. All right. So early warning signs to watch for include those subtle changes like confusion, altered mental status, unexplained fever, tachycardia above 90. Remember, not 190 for our SIRS, and hypotension. But again, remember, hypotension is a late sign. So we shouldn't be just going, oh, well, our patient's not hypotensive. It doesn't matter. If they're running a fever, they have a high white count, and we suspect an infection, or any one of those 4 signs, we need to be reporting that and jumping on that way sooner than normal. So recognizing these early red flags allows us to intervene before the patient progresses to that severe sepsis or that septic shock. So high-risk groups include patients who are immunocompromised, those post-transplant receiving chemotherapy, or with profound neutropenia. For these populations, infection can progress to sepsis much more rapidly, increasing both metabolic and oxygen demand. So this is why early recognition and treatment are critical. And remember, sepsis is a continuum. In this unit, we're really only focusing on the first half and identifying that sepsis. And then again, like I said earlier, we're going to cover severe sepsis and that septic shock in a later unit. So all of this is going to come back, guys. So if you don't know it now, you're going to need to know it here in a couple units. But please know it now because there's definitely questions on this on the quiz. So when managing sepsis, time is critical. The sepsis bundle should be initiated within that first hour of recognition. This includes drawing blood cultures, checking lactate, and starting broad spectrum antibiotics. And then of course giving fluid resuscitation. So fluid resuscitation is typically 30 milliliters per kilo of crystalloid fluids. Lab monitoring is essential to track disease progression and response to therapy. So lactate's a key marker. If it's elevated above 2, it signals tissue hypoperfusion and poor oxygen delivery. Additional labs like CBC, coagulation studies, and procalcitonin really help guide therapy and track systemic response. If the patient remains hypotensive after fluids, which we're not going to talk too much about this because we're going to hit this in Unit 6, then we're going to need to start, vasopressors or something like that. But again, we're going to focus on when shock is absent because we're going to cover shock in a later unit. So the nurse's role in surveillance really cannot be overstated here. It is your job to notice these very small, subtle signs and symptoms. Continuous monitoring of vital signs, urine output, mental status is critical. Early recognition of those changes and prompt reporting can be the difference between stabilization and progression to that septic shock. So febrile neutropenia is a true oncologic emergency. It is defined as a single oral temperature of greater than 38 and sustained of greater than 38 for more than an hour. In a patient, and remember 38 is 100.4, which is a temperature in Fahrenheit. In a patient whose absolute neutrophil count, so their ANC, is less than 500. So this is common in chemotherapy patients because their immune system is profoundly suppressed. The most common pathogens include either the gram-negative organisms, such as like Pseudomonas, or gram-positive cocci, like Staphylococcus, or even fungal infections. Because these patients lack the immune response to mount a strong defense, infection can progress rapidly to sepsis or septic shock. Immediate intervention is required. So broad-spectrum IV antibiotics must be initiated within 60 minutes of that fever recognition, even before culture results return. Okay, so we need to draw those cultures, and then I don't care what those cultures say, we need to get those antibiotics, those broad spectrum antibiotics on board even before the cultures come back. We need to draw them beforehand, but we need to give those antibiotics without delay. Because timing is critical here. Delays in antibiotics are associated with significantly higher mortality rates. So nursing responsibilities include obtaining those cultures prior to starting the antibiotics, maintaining strict neutropenic precautions, and of course closely monitoring for signs of sepsis or shock. Patient and family education should should stress that even low-grade fevers in these patients demand urgent evaluation and treatment. Pleural effusion and cardiac tamponade are critical complications that can develop in oncology patients, especially those with lung, breast, or metastatic cancers. With pleural effusion, fluid builds up in that pleural space, limiting lung expansion. This can lead to dyspnea, diminished breath sounds, and sometimes tracheal deviation if that effusion is large enough. A chest X-ray, ultrasound, or CT can confirm the diagnosis, and a thoracocentesis may be performed both to relieve the symptoms and analyze that fluid. Cardiac tamponade, on the other hand, this is even more urgent. So here, fluid collects in the pericardial sac and compresses the heart. This prevents it from filling properly, and then, of course, contracting properly. This reduces cardiac output and can quickly progress to circulatory collapse and cardiac arrest. So clinically, we need to be looking for that Beck's triad, which is that hypotension, jugular venous distension, and muffled heart sounds. Echocardiography is the gold standard for diagnosis here. Both conditions are considered oncologic emergencies, so nurses play a key role in recognizing symptoms early, monitoring for rapid deterioration, and preparing patients for urgent interventions. So for that pleural effusion, that's going to be that thoracocentesis, or pericardiocentesis for that cardiac tamponade. And then just remember, this is fluid that's building up outside of these organs. So in the lungs, it's not inside the alveoli. So it's outside of the lung tissue, which is, it's compressing the lung down. So you won't hear crackles or anything like that. You'll just hear diminished lung sounds. So I do want to point that out. Some students kind of get that confused. Leukostasis is a medical emergency seen most often in patients with acute myeloid leukemia, or the AML. It happens when white blood cell counts rise to extremely high levels, often greater than 100,000 per microliter. So these abnormal rigid blasts clog small blood vessels, causing impaired circulation and decreased oxygen delivery to vital organs. So these are these little tiny white blood cells that just get improperly they just kind of start proliferating a lot. So their white counts like 100,000, like it's insane, but they're little immature cells and they're not really doing a whole lot, which is what clogs up the blood vessels. And it makes the blood very viscous, which again, feels a lot similar to our sickle cell anemia, right? So that blood gets very thick, it gets very viscous with all those immature white blood cells, the leukostasis. Remember, leuko means white blood cell and stasis means stagnant, right? So it's viscous, it's thick. And then of course we need to give fluid. So this is kind of, think of your sickle cell anemia patients, and that's kind of what this is, but instead of our red blood cells being sickled and it's not genetic, this is usually cancer related. So this usually happens, so clinically patients will present with dyspnea from pulmonary involvement, very similar again to our sickle cellers, neurologic symptoms such as confusion, headache, or stroke-like changes as well because of those little clots kind of happening everywhere. And then of course evidence of organ ischemia because again of those little clots forming everywhere. And not the red blood cell clots, just your white leukocytes, those little baby immature cells kind of clogging everything up. So these symptoms reflect that high blood viscosity and poor perfusion because it's clogging up all your vasculature. So diagnosis is made with a CBC, which shows that hyperleukocytosis. Imaging can also reveal lung infiltrates or cerebral edema, and labs may show rising lactate or coagulation abnormalities, and that's just because the blood is having trouble getting through that circulation. So again, this is that true oncologic emergency, which requires urgent interventions to reduce the leukocyte burden and restore perfusion. So our definitive care is that cytoreductive therapy, such as hydroxyurea or leukapheresis. Okay, so leukapheresis is a big thing. That's kind of our definitive care, and that kind of just like washes the cells out, kind of takes out those white blood cells. But however, very much like our other patients, like our sickle cell patients, we need to give IV fluid hydration first, okay? So as we wrap up hematology, immunology, and oncology content, here are the key clinical priorities to keep in mind, okay? So first, always recognize hematological red flags. So critically low platelets under 20,000, neutrophils under 500, or hemoglobin below 7 are dangerous thresholds that require urgent nursing action and provider notification. Also, we need to review transfusion best practices. You guys are going to have a lot of transfusion questions, not just on this quiz, but then again on the midterm and again on the final. Blood transfusion safety is huge, not just in this course, but also on NCLEX. So always confirm patient identity and blood product match. Use normal saline with blood. Check vitals before, during, and after, and never leave the patient during the first 15 minutes, since that's the highest risk window for hemolytic and allergic reactions. And also, please wear gloves during blood transfusions and when you're handling that blood product. That is the one that students miss. So for post-transplant patients, monitor closely for infection, graft versus host disease, or graft rejection, okay? So education on immunosuppressive therapy adherence is critical to preventing complications. Don't forget oncologic emergencies, okay? So that's that febrile neutropenia, the leukostasis where we need to give, that we just talked about it, high dose IV fluids, and then of course the leukapheresis, pleural effusions where we're doing the thoracocentesis, and of course cardiac tamponade where we're doing the pericardiocentesis. All of these require rapid recognition and immediate interventions, such as antibiotics, cultures, and emergency drainage. And then, of course, finally, your NCLEX strategy tips. So always prioritize your ABCs, infection prevention, and patient safety. So look carefully for STEM wording like most critical or first action. Sometimes NCLEX likes to trick you, and all of the things you're going to do or all of the answers are going to be things that you're going to do. All four are correct, but what are you going to do first? What is the most critical? So always look at your ABCs or use kind of like that Maslow's. Is there something airway, breathing, circulation, or safety that I need to address first? And then, of course, know your normal lab values, and not just lab values, but know your normal vital signs. Just know your normals. What is normal? Because even if you can't pinpoint, and this goes back to real practice, guys, even if you hear something and you're not sure what it is, you know enough normal to know that what you're hearing or what you're seeing is not normal. That's when you don't have to know all the answers. You just have to go grab somebody once you recognize that it's not normal, and try to figure it out and report it properly, okay? So that is my speech and final takeaway for this unit. So if you have any questions, please reach out. Email is always the best way to receive a timely answer from me. And of course, I will see you in the seminar.